Hi, everybody. I'm Tash.
And I'm Demo.
And we are so excited to bring you this week's episode of The Barry Chronicles. Today, we are talking with the one, the only, Dr. George Balalis.
Ooh.
This episode of The Barry Chronicles is proudly brought to you by Bariatric Support Australia.
Hey guys, so we're here with Dr. George. I am so happy to have you on the Barry Chronicles again. Thank you for coming.
No, thanks for having me, and it's always a pleasure, and really looking forward to it.
Yeah, so let's just dive in. Some of the questions that we've been getting asked in our community recently revolve around, like, people have the sleeve, but then we get asked, should I just go straight to bypass? Because it seems like a lot of people have the sleeve done and then they need revision surgery, 2 years down the track. Should I just go straight for the bypass first up?
Look, I think all operations have a revision rate.
Yes.
I don't think that the sleeve has any higher revision rates than a bypass. I think that reoperation rates for a bypass can extend even 10, 20 years after the operation. The risk of an internal hernia, the risk of an issue with your small bowel, ulcerations, that risk never goes away. And so that risk is very low, but it never goes away. And I think that's important to recognize that as a major difference. Sleeve risks are more acute. So the first 6 weeks in particular, there's a risk of a leak, and then there's a risk of reflux. And other than that, I think the sleeve risks are more acute. And so that is, I think, one of the important points to make. So when people are discussing sleeve versus bypass, I think it's important to recognize the subtle differences in the risks and how that affects a particular person.
Yeah.
So
I think when I've thought of reflux, especially like before I had weight loss surgery, I would think of reflux and just, it's when you sort of burp after you have too much to eat at night. But then when you've got this stuff coming up.
Yeah, that's reflux. Yeah. So that's water brash, the feeling of stuff coming all the way up your esophagus, that's volume reflux. That can't be fixed with a tablet.
Okay. So is it something that needs to be fixed?
I would say that I discuss that with patients and I would encourage them to have that fixed because there is risks and long-term risks for having volume reflux. So things like esophagitis, burning of your esophagus, that can be helped with pantoprazole and other drugs. There's a risk of aspiration, and it's quite an unpleasant and uncomfortable feeling. And if that bothers somebody, I think they should have it fixed.
Yeah. I mean, you've had it as well, haven't you? And it hasn't just been a sleeve issue.
No, and that's the other misconception. Bypass patients get reflux.
Yes. Yeah.
They do. And absolutely, the rates of reflux are far less. But if in particular, if you have an issue with your pouch or if you have a hiatus hernia after your bypass, or if you have a partial obstruction or the way that it's set up is not quite right, or even just because you have a lax gastroesophageal junction, you can have reflux after a bypass. And it's important to interrogate that. And it's important for patients to return to their surgeon.
Yes.
To be interrogated for that. Swallow tests, endoscopies, CT scans, even laparoscopies. Yeah.
So I guess that's an important question then to ask at our, initial consult is, do you do a repair or, can I get help if this does happen?
Absolutely. I think at an initial consult, a patient is more than entitled, I would say. I would encourage people to talk about symptoms like reflux.
Yeah.
Reflux is something that's really important to decipher and to assess and to figure out, is this reflux that's happened only with recent weight gain, or is this reflux that I've had a long time? Does this wake me up at night? Do I have, volume reflux? Is it heartburn? Is it just, a bit of pain after having too much of a particular meal or food, like something acidic? Those things are important to tease out because some of the most miserable post-op symptoms is a reflux. Reflux can be miserable for people, and I think it's Yeah, and nobody wants their patients to have reflux, and I think you have to talk to people and really, think about a bypass, think about assessing the hiatus, and making a concerted effort to fix that if it's needed.
Yeah, that's great advice. Something else that comes up a lot is hair loss.
Yep, happens.
It
Definitely happens,
yeah,
particularly the first 6 to 12 months. And I think after that, we see that hair comes back, ensuring that your vitamins are corrected, ensuring you're on the right vitamins, and that you're having enough protein in your diet. And, again, dietetics advice and support is so important.
That's right.
yeah,
Yeah.
But,
yeah.
but I tell people, I reassure them, yes, first 6 to 12 months, for sure that can happen. But most of the time, by 2 years, that's back. Yep.
Mm.
Wow.
That's good for people to know.
It is good, isn't it?
Yeah.
It sort of gives that sort of bit of hope.
Bit of confidence.
Yeah, and it's a bit exactly, and I think those things are important. Enough protein and vitamins, and to recheck, and you may need further blood tests and making sure that all your micronutrients are corrected and things like that. So.
Yeah. Like, how important is the post-op? Sort of the 2 weeks of liquids and then puree, soft.
Post-op?
Yeah.
Yeah, I mean, we're never going to have a randomized trial to check what happens if you go straight to solids.
Thankfully.
I do think that a period of time, by 6 weeks, things are healed. By 6 weeks, your anastomosis is healed, your suture line's healed, and you're able to tolerate, normal food. And so I think that period of slow escalation or progression of food is important. And for me, that's really important. And we really stress that. Yeah. And so I know people really struggle with things, particularly puree. And I think there are alternatives. You can continue on more liquid type stuff for a bit longer. And there are not too bad sort of delivered puree food that's high in protein, that's specific for post-bariatric patients. That you can order online and things like that. So there are alternatives, and there are also really good, recipes and cookbooks around that. The girls from Nutrition for Weight Loss work in our rooms and support all my patients. They have good resources that can help with that as well.
Yeah,
that's awesome.
And their Elevate course, which is amazing.
Yes.
Yeah. So that's people can get support out there. It's not like there aren't more resources than there ever has been. Is current.
Yeah. Which is actually exciting.
Not like the dark hole.
And you guys are part of that. The fact that people have places to go and to talk to people and have a community is so important.
Yeah.
So.
I was going to ask you, when in I guess that whole topic of things are like they've never been before. We have more information. We have new things happening all the time. What are the new things? Is there any new things on the horizon within bariatrics?
There may be. I'm actually headed to, and I'll have to talk to you guys about this maybe another time about my experience. But I'm headed to Sydney in a few days. To be witness to a trial that's being undertaken by some bariatric surgeons there, which is very exciting. And look, I'm going through the preliminary discussions of looking at that in South Australia. But regardless, I'm very excited about witnessing these new procedures and
awesome.
how that'll all go. So can't say too much about it at the moment, but there are definitely new things on the horizon, and very excited about that. Yeah, probably can talk to Damo a bit more about that in a couple of weeks.
That'll be so good.
Amazing. I'm really excited because I love technology, and I love seeing things progress and sort of come of age, I suppose. And that's where I see like the weight loss surgery, bariatric surgery, it's sort of coming into its own where, it's a lot more recognized.
It is, and it's evolving as well, and people are aware that it makes a really big difference to people's lives, and they're able to, improve their life, quality of life, live longer, get off some medication.
Exactly.
Yeah.
Exactly right.
There's a few terms that we keep seeing pop up, and people have asked about being re-sleeved. I was
That's not a thing. That's not a thing.
Yeah, I've looked into it and I was like,
that's not a thing. No, yeah.
It's good to know, because I think that there are times, and I know that.
Is that being done in Australia?
Yeah, there are some surgeons that are offering what they call
A re-sleeve. That's why we're asking.
I'll be, and in the nicest possible way, I'd be very cautious about that.
Yeah. Because and this is what I love about the podcast and about talking to people like yourself, because traditionally we would hear something from a surgeon or a doctor, and that was it. It's like we didn't question the medical professionals, and it's not that we don't respect people's abilities and
no,
that.
Of course, yeah.
I think it's important to understand that sometimes
there are variations. Yeah, there
Mm.
are variations in practice, and I think that's again why it's important to get a second opinion. I don't think there's any issue with that.
Yeah.
Wholeheartedly recommend that patients get another opinion if they're concerned or they have a complex situation or there's any issues.
Yeah, because it really is about the consumer outcome, isn't it?
At the end of the day, we're looking after people. We're trying to help them. There are variations in practice and thought process, and I think that's okay. But the patient needs to figure out what's best for them as well sometimes.
Yeah.
Last time we spoke, when you were explaining about the balloon and the reasons why it might be able to be used, it actually really impacted me. And I've spoken to Damo a couple of times since then, and I've said, really, my eyes were really opened. I clearly had some quite set beliefs about some things, and you were able to help me realize that there are situations where those types of procedures are very, very useful for people.
Absolutely. It's not surgery. It's not gonna get the same outcome.
Yeah.
We know that. And you have to be very clear with people and have to have very clear parameters of what's to be expected and what they can expect. It's a mindset tool, essentially, and it's really good at that. And if you're at a lower BMI point and you're not really eligible for surgery in particular, it's a great opportunity to improve on things. It's very safe. I mean, in our practice, it's looking after patients. It's very safe to have a balloon.
Yeah. I mean, I think it's great for the people that are of a higher BMI, or it may be dangerous to have an anaesthetic.
So the Allurion balloon can't be performed above a BMI of 40 in Australia.
Okay.
That's just the guidelines. Overseas can. I adhere to those guidelines and wouldn't do it in a higher BMI, but there are other balloons that can be done. And yes, they have been performed as a bridge to surgery, and it makes a lot of sense. But I think medications have helped a lot with bridge to surgery, and I use them liberally, in particular.
That's very interesting.
Particular prior to surgery. And, I am, open disclosure, I am talking to a group of doctors in a couple of weeks for Novo. I'm on an honorarium for them and help out with educating other specialists and other GPs about new medication, because I think it's really important and to be used appropriately.
It's something that I've been looking at, the Mounjaro
and Wegovy.
Because I guess I still do have a few kilos that I would like to drop, but also
that's
with
okay.
the type 2 diabetes that's sort of resurfaced, and that I'm sort of just I'm excited that we're not sort of stuck with one option anymore.
Correct, and that's what it's about. It's providing options to people. Ozempic is now separate to Wegovy for for management, and I think that's really good. People need to seek help from their practitioners in regards to prescribing and things. Yeah, I think that's important.
How do you incorporate it? Like if someone has had surgery, when would you sort of consider writing that script?
Look, it's a case by case basis. Really, it really is. I really think medication is fantastic as a bridge to surgery. I think it really helps and gets people, shrinks their liver, gets their weight down, means you're more likely to be able to perform a gastric bypass on somebody who's, particular male, BMI above 55, that kind of thing. And, for me is, fantastic, and it's really improved surgical outcomes.
And that's
in regards
exciting.
that's fantastic. I had a revision patient just on Tuesday, and he has lost over 30 kilos preoperatively, so from well over 200 to just bang on 200 kilos, and that was a relatively straightforward operation where previously it may not have been that way. And I think that's all about the preoperative weight loss.
Amazing.
I think that's, for me, that's an amazing opportunity and really beneficial for patients. Post-operatively, I think it's a discussion. Again, expectations, risks, cost, benefit, all of those things.
So could we talk about, because I don't know if we talk about it enough, the expectations that we set as a bariatric person. I know what the statistics are. And should we being comfortable that is the range that we could expect to be at, say, 5 years down the track?
Look, I think as we know, weight is not the whole story.
That's right.
It's one metric. There's so many things. People, yes, they lose weight, sure. But they have better mobility. They are able to look after their kids because they have more energy. They're able to kick a footy, or they're able to get into a plane and put in a normal normal belt. There are so many non-weight metric related benefits. People are feeling happier. They have they sleep better. They're more comfortable and they feel better about themselves. They're able to shop at a normal shop. Whatever it may be, all these things that seem like they're pretty, some people go, oh, look, it's so silly, but I'm so happy now because I can, it's not silly. It's actually really important. And yes, on top of that, you're having major health benefits, and I'm not trivializing that. I think that's really important. But there are other health benefits that can't be shown just on scales, if that makes sense. Diabetes resolution, sleep apnea resolution, improving in cholesterol and blood pressure, all these things, they're not just related to the number and the weight loss. And I think that's important to recognize.
I totally agree. I went into my bariatric procedure because I wanted to be around for my children.
Yeah, exactly.
That was it.
Yeah.
That was, and I didn't even really have, I didn't have a goal weight at all. I just, one chin was kind of, I was hoping for. Oh,
hey, look, again, that's not a weight, that's not a weight number. That's that's fine. Yeah.
There were just like some things that I wanted for myself. But as I went along, I realized, for me personally, I went far under what my surgeon expected, and I sit about 30 kilos under where he expected that I would stop. And I don't particularly know why that is or how that is. It just seems to have been.
Look, the body is a powerful thing, and it's very tricky to predict these things.
To understand. And then I have some very dear friends who have been disappointed with their results. I mean, I think that it's just still such a wonderful, life-changing thing that they've
Absolutely.
done for themselves.
Yeah.
And then I guess from my own perspective and my own journey, I certainly have had my share of complications at that other end as well. So, maybe
And
it's
look,
a little
and
bit
this
of a
is,
trade-off.
well, exactly. It is a trade-off, and that's why it's important as a surgeon to explain to people what some of those risks and benefits can be,
Yeah,
and the percentages and what that all means.
yeah,
So people are aware, and they understand the risks, they understand the benefits, they understand the expectations. I still think it's a very powerful tool to change people's lives. Don't get me
I
wrong,
agree.
but you have to be well informed as a patient. Yeah.
Yep.
Wow.
So
Yeah. No, that's great, because I mean, we every Monday we do a thing, our group, called Beyond the Scale, and
exactly, that's perfect.
it's like celebrate our victories that have nothing to do with a number on a tape measure or the scale.
Exactly.
And I'm loving it. And then Saturdays we have people that have started, they're posting videos from their park run that they're doing.
Excellent.
And
I did a 10K run. I didn't, step up to the marathon. I'm going to slowly work my way up there maybe. But on the finish line, a lady just overtook me. I wasn't making any record pace, let me tell you. And she flew straight past me. She was on the up, and I half collapsed on the finish line. And she turned around and she was like, "Oh my God, George, great to see you." It was one of my patients, which sounds like a
I love that.
made up story, but it's the truth. And she's like, come meet my family, and I'm barely struggling to breathe, and that's amazing. Big hugs all around and all the rest of it. And she truly said she wouldn't have been able to make that run a year ago. And these are the kind of things that people get into doing. And I think it's actually really important to participate in exercise and resistance training after surgery. And, they're amazing things that people achieve. Yeah. So
I love that.
she was pretty proud to have beaten.
I bet she was. She would have been like, yeah.
It's, which is good. I'm glad. So, but they're the things that make you very happy and very proud of what you do, and these are things that keep you going.
Yeah. I love that. So when we're looking at sort of the long-term outcomes and that kind of thing, I know that we have some people that ask, is the bypass reversible?
Technically, yes. Technically, you can reverse a bypass, but it really leaves people with pretty severe reflux, and you would have to have a major reason to do that.
Yeah. No, I think that's a great response to it, because
I would, when talking to a patient, I tell people that really both operations are permanent. And that shouldn't be a reason to go for a bypass over a sleeve.
Yeah.
Even though it feels like it's a bit more permanent, sleeve being more permanent than a bypass, they're both permanent, essentially.
Yeah. No, I think that's good information, because I know Tasha's had people say to her, "Why don't you just get it reversed?"
Get it reversed. You can, but you will have pretty bad reflux.
That's right. You can, but then what I found to be true for me anyway is that any time I opt for a surgical intervention, I could then be asking for more surgical interventions. I
promise we don't. We try our best not to have that situation.
I know. But I've definitely just taken the viewpoint that my bypass is forever.
I agree.
Well, I guess I sort of did that with my back as well. I was chasing one thing after another, trying to get that unicorn that I'd be pain free. After over 30 procedures on my back, I just went, when does this stop?
Yeah.
Wow.
And, working with, a team, pain specialist and GP and everyone, I think I'm finding it easier to cope
Yeah.
because so much of it was a mental health
Yeah.
thing.
Yeah.
Mm.
And look, everyone's situation is different, but yeah, I agree. Sometimes more surgery is not necessarily a good thing.
Mm.
Yeah.
That's right. Yeah.
So
So we've just had the release of the latest data from Monash from the bariatric
PSR.
yes
Yeah.
BSR.
Yeah.
So what were you sort of looking forward to seeing in that?
Look, I always like the weight loss outcomes. I show people that in my consult, and just to reassure them that, a sleeve and a bypass aren't that dissimilar. And, we even sometimes go through the numbers
Yeah, the
because
outcomes are
people
very
are,
similar.
yeah, they're not that different. And I think it's about good support, good routines. There are no tricks. And
That's
I
right.
think, yes, there are some people that would be better with a bypass, and there are some people that would be better with a sleeve. But I don't think that one operation fits all. And I think that's the key. They're both good operations.
Yeah. Do
So
you think this sort of research will lead to people being able to make those better decisions in which surgery they go for based on?
I think it has already. I think absolutely that's the case. I think people feel as if they can make a decision about a particular surgery knowing what the expectations, can be or should be or on average are. And that's empowering for people, and I provide that information to patients during a consult. I think that's important. Yeah. Why not? Yeah.
Yeah.
Mm.
It's and I love talking to the team that run it and Professor Wendy and they're so passionate about it and they really do care about the patient outcomes.
Oh, it's a fantastic resource for patients and surgeons around Australia. I've worked with Wendy. I've worked at the Alfred and where the BSR is based, and work with the team there. And yeah, it's a great bunch of people who are really making sure that we have that data to use in a clinical setting, in particular about surgical outcomes. So that's where it's based, is surgical outcomes. So risks and benefits, and data in regards to number of procedures and types of procedures and what's being done around Australia, which is really important. Yeah.
When do we think that we're really going to start, or are we already seeing these, some good results from the combination of GLP-1s and surgery? Do you think it's making a difference now?
I think like I said, I think it really helps people preoperatively.
Yeah.
It really does. I think that for me personally as a surgeon means safer surgery in some patients, and I think that's great.
Yeah.
Whether or not we see the goalposts continue to shift, what I mean by that is patients looking for 30 to 35% weight loss with an operation. Maybe we can get that to more like 40% if we use adjunct therapy as well, and those kind of things, and that's the evolving space. So the use of medications on top of surgery or prior to surgery, and what that looks like in regards to the end weight loss outcome, and I think that's fascinating, and that's evolving as medication gets better as well.
Yeah.
So I think, in regards to weight loss medications, it's an evolving space. It's an exciting time, but I think you have to understand and think about it as a lifelong treatment.
Agreed.
At the moment, that's how we see medications, and that's important to discuss when prescribing. But it is definitely an effective adjunct, something that I use every day.
Yeah.
Yeah.
Do you think there's how much influence does what's happening overseas have on what's happening in Australia? Like, I know there's so many studies being done.
There's lots of work, lots of research, lots of phase 3 trials, lots of new medications, lots of things going on at the moment. it's always important to have a good understanding of the literature and how it's evolving, and how it's going to affect your patients. It's really important to just keep an eye on what's happening and stay up to date, for sure.
Yeah.
And sometimes we're a little bit late because of particular regulations and things. So then we have a bit of a better understanding of how it's going to maybe affect our population.
Yeah.
So
yeah.
At the end of the day, it's everything that we try and help people with is an option for them, and it's all about supporting people with changing their routines and getting their health back, which is good.
Yeah, amazing. Dr. George, thank you so much for joining us.
Thanks for having me, and we'll hopefully see you soon.